Niacin's fall from clinical grace is one of the more instructive episodes in recent medical history, not because niacin failed, but because of how the evidence was misread and misrepresented. In 2011, the AMHI trial made headlines for showing that adding niacin to statin therapy provided no additional cardiovascular benefit. In 2013, HPS2, Thrive reinforced this finding. The medical community largely interpreted these results as proof that niacin doesn't work for cardiovascular outcomes. Prescriptions plummeted. The supplement community followed suit, treating niacin as outdated and discredited. The problem is that both trials were studying the wrong question. AMHI and HPS2, Thrive both tested niacin added to patients already on aggressive statin therapy, patients whose LDL was already driven to near optimal levels by maximum dose statins. In this context, you're asking whether niacin provides incremental benefit on top of near maximal pharmacological lipid lowering. The answer is no, not because niacin doesn't work, but because you've already achieved most of the achievable cardiovascular benefit through statins, and there's little room for additional improvement. This is a ceiling effect, and it's a study design flaw, not an indictment of niacin. There's a second design problem. Both trials used extended-release niacin formulations, which have different and less favorable safety and metabolism profiles compared to immediate-release niacin. Extended-release niacin is associated with higher rates of hepatotoxicity, which contributes to adverse event profiles that can complicate outcome interpretation. These formulations were chosen partly for patient tolerability because they reduce flushing. But the pharmacological differences between formulations are significant enough that results shouldn't be uncritically generalized from extended release to immediate release or to nicotinic acid monotherapy. The actual therapeutic context in which niacin remains genuinely valuable is patients who are statin intolerant, a significant population, and patients with specific lipid phenotypes, particularly low HDL and high triglycerides, that statins alone don't adequately address. For these individuals, niacin monotherapy guided by a knowledgeable physician represents a viable, evidence-supported option that the AMHI and HPS2 Thrive headlines have unjustifiably stigmatized. Scientific literacy requires distinguishing between doesn't add value to maximum statin therapy and doesn't work. These are categorically different conclusions, and conflating them has done real clinical harm.